Now we'll start with the fifth session for today. RNTCP has released a national strategic plan for tuberculosis 2017 to 25 for the control and elimination of TB in India by 2025. The four strategic pillars are to detect, treat, prevent, and build. So the topic for this session is RNTCP update. The chairpersons are Dr. Subramaniam and Dr. Banuchander. Dr. Subramaniam, he has completed his MBBS from Stanley Medical College. He did his DNB Family Medicine from Indira Gandhi Government General Hospital, Pondicherry, and he has got the Best Medical Officer Award from Pondicherry Government, and he is currently working in Newborn Care Unit in Rajiv Gandhi Government Women and Children Hospital, Pondicherry. Dr. Banuchander, he did his MBBS from Janagi Medical College, Janakpur. He did his DNB Family Medicine from KG Hospital, Coimbatore, FCD, and he is the secretary of AFPI-TN chapter, and he is now working as a consultant physician and diabetologist in Vadamalayan Hospitals, Madurai.
Speaker for this session is Dr. Velkumar. He did his MBBS from Tirunelveli Medical College and MD Pulmonary Medicine from Stanley Medical College, Chennai. He is the senior consultant and head of pulmonology and sleep medicine at MMHRC, Madurai since 2012. He has performed more than 1,500 bronchoscopies and he has received the Lupin Gold Medal Award, Professor K.V. Krishna Swami Gold Medal and Santosham's Memorial Medal by Dr. MGR Medical University. He has presented various papers at NAPCON 2010 and 2011. He has also done a research work on the effect of different treatment modalities on COPD exacerbation in patients with severe to very severe COPD. Over to the chairperson.
Welcome all. After the post-lunch session, we have a awakening session for TB update. Since we all know that TB is one of the most common mortality of top 10, it has been there. In infectious disease, it is one of the highest mortality rate is there. So today we have along with us Dr. G Velkumar sir, the eminent speaker and the pulmonologist practicing in Meenakshi Mission Hospital for the recent NTEP updates. Over to you, sir.
Thank you very much. Respected seniors and my dear friends, a very good afternoon to every one of you. In fact, it's not an ideal time to have a talk, particularly during the postprandial or drowsiness or nap time. Probably அதனால தான் பிரணீதா மேடம் எனக்கு டைம் இந்த ஸ்லாட்ஸ் கொடுத்துருப்பாங்க போல். I'll try to make you have a good and deep sleep, okay? ஒரு 40 minutesக்கு make sure that we'll have a good session, okay? And I would like to thank organizers of family medicine for giving me this opportunity to have a talk on the topic given was RNTCP, but you all know it has been renamed as National Tuberculosis Elimination Program with the target to eliminate tuberculosis by the year 2025. In fact, prior than the global target of 2030. Okay, with this background and usually our presentation பார்க்கும்போது I will see how many slides a speaker is going to present. This is my first thing. This 30 minutes or 40 minutes is going to be tough ஆங்கிறது தெரியும். So I got 65 slides. So keep yourself mentally prepared and have a nice time. In fact, I was discussing with Dr. Pranitha and other family medicine fellows, what do you expect from me, who are all the audience is going to be, and she was telling that most of them will be postgraduates. They wanted to know everything about tuberculosis. The immediate response was this. In fact, I don't know nothing about tuberculosis, particularly drug-resistant tuberculosis, which have been evolving, and government is doing a wonderful job to make sure that you eliminate tuberculosis from our country to decrease the incidence and prevalence of particularly multi-drug resistant tuberculosis or extensively drug-resistant tuberculosis and so on. So the guidelines have been changing every now and then. In fact, to be honest, usually for other presentation, I'll be preparing for 1 or 2 days. And for this preparation, I have prepared for around 7 days, reading all drug-resistant guidelines. Morning car leyume drug-resistant guidelines book oda dhaan poren. In fact, I'm not going to present everything. I wanted to talk basic things about me, but what I thought is, unless I know deeply, how can I I usually think that whenever I'm going to give a presentation, it should be beneficial for both of us. In fact, I have been accompanied by DD Tuberculosis from Sivagangai, he is my colleague, so that if at all any doubt related to programmatic management, he will be able to guide you. Because you people are the primary people who are going to diagnose tuberculosis and make sure he or she has been referred to us earlier, and particularly in the patients with comorbidities, you should understand that it is essential to make sure you treat the tuberculosis adequately and permanently. The word is important, adequately. Even if you put an ATT for a sputum positive tuberculosis patient, if he takes ATT for 1 month, he is going to do well. If you do not counsel him, obviously with the background of smoking history and alcoholic addiction history, he is going to default his treatment and come back to you after 1 year. By the time he is going to spread to others, particularly drug-resistant bacilli, this is how innocent people and poor people are getting affected by tuberculosis. So it is your duty first as a family physicians to understand the importance of clinical understanding, history taking and diagnosis of tuberculosis, so that to prevent further emergence of drug resistant, and your job is the predominant one to make sure that we achieve the target of TB elimination by the year 2025. So with the background, you have to understand that TB can affect anyone. It's not that TB will be affecting low socioeconomic status, TB will be affecting only poor people who are only undernutrition, nothing like that. Please understand that you go with a neutral mindset whenever you encounter a patient, irrespective of a socioeconomic status, age criteria or whatever it is. You have to understand that TB can affect anyone, and TB can occur in any age group. Okay? And then TB can affect any organ in the body except when skin and nails in solikalam. We used to discuss TB can affect any organ in the body except kepanga. Just for fun, skin and air thavara, it can involve any organ in the body. So as a whole, you need to have a systemic examination thoroughly and history taking to make sure that you diagnose tuberculosis at the earliest. And somebody was talking in the morning, it should be an interactive session rather than a monotonous. Please understand that it's a lecture. So I can talk, if I have to interact, what are all drugs for first line tuberculosis, what are all the drugs for second line tuberculosis, I think 40 minutes will not be enough. So hope you understand that. If at all any questions, we can discuss after 40 minutes. If you are ready, I can ask so many questions. Okay. And please keep in mind that you have to understand that you have to know about the comorbidities. That is the foremost important thing. Please, please, please make sure you don't treat only the disease. Please make sure you treat the patient as a whole. That is the foremost important in treating any of the illness throughout the situation. You got my point? And make sure you understand the comorbidities. Suppose if at all, if you have an HbA1c with a patient of 12 and he is having sputum positive tuberculosis, you may be completely 100% perfect in treating tuberculosis. But unless you correct the underlying diabetes status, this patient is not going to be benefited by whatever effort you put in treatment of tuberculosis. So you make sure that incidence of comorbidities and prevalence of tuberculosis in comorbidities is going to be much higher, and carry-home message is morbidity and mortality is going to be much higher in patient with tuberculosis, particularly the common 3 condition, diabetes, HIV and pediatric population. You should make sure that you treat the diabetic condition aggressively, predominantly with insulin, to make sure unless you suppress the diabetic condition, these patients are not going to improve, or the relapse rate or recurrence rate is going to be higher with this kind of population. So you have to know that the development of tuberculosis in HIV patient is approximately 21 times higher, and 25% of all deaths in HIV patients are due to tuberculosis. That's the most important thing. And India is a country which high burden of diabetic mellitus, both type 1 and type 2 diabetes mellitus. You have to understand that diabetes mellitus triples the risk of tuberculosis. So hope you got my point that any patient with diabetic, with tiredness, fatigue, chronic weight loss, please make sure you do not attribute all the symptoms to diabetes. You have to understand that he may be suffering from an underlying coincidental secondary infection, particularly tuberculosis. So 20% of all tuberculosis in India has got diabetes mellitus. Obviously, tobacco risk factor, addiction, de-addiction, these are all going to increase your defaulting status, and patient is going to have persistent symptoms and poor outcome. I told you undernutrition, strongest risk factor for developing tuberculosis, approximately of 50%. What is important is why it is necessary to understand that is it's a completely curable disease and treatable disease and preventable disease. we have to make a point that it's not like a non-infectious disease which have gotten poor prognosis. It is completely treatable disease, curable and preventable. Unless we concentrate both on the comorbidities or the patient is not going to turn to you back, you can make sure you as a primary physician itself can cure the patient 100% so that you can reduce the incidence and further propagation of drug resistance in the community. So this is what I told you. Overall risk factors, suppose if you have a latent tuberculosis infection where the tuberculosis is endemic, you have got a lifetime risk of developing into a tuberculosis disease. What I am telling is infection is different from disease. We all may be infected with tuberculosis, but disease is different. That's where the latent tuberculosis, the IGRA test, Manto test differs. Okay, it all diagnose your infection, not the disease. You can have an fetching evidence in making sure you are supporting a diagnosis, but disease is different, infection is different. So latent infection can develop 10% lifetime risk. Whereas in diabetes mellitus, I told you it triples the risk. It's approximately 30%. So over a lifetime of developing into a risk, and make a point that these patients who are having poorly controlled diabetes have a higher tendency to develop drug-resistant tuberculosis. Presumptive extensive drug resistant and multi-drug resistant or extensive drug resistant tuberculosis. In HIV co-infection, I told you each year the risk of developing tuberculosis infection is approximately going to be 7 to 10% compared to the lifetime incidence of 10% with latent tuberculosis infection. That's what I told you. 25% of mortality in HIV patients are due to tuberculosis. So this is the first national survey which has been published. So the concept of National Tuberculosis Elimination Program, why it is absolutely essential to make sure we control the tuberculosis is because of this drug chart which is available. So the incidence of resistance, particularly in India, is increasing. Approximately multi-drug resistant, we all know, resistant to isoniazid and rifampicin with or without resistant to other drugs is defined as multi-drug resistant tuberculosis. The incidence is approximately 6.19%. And extensively drug resistant tuberculosis is approximately 1.3%. So we need to make sure that previously gene expert drug resistant kandupidikirana, it will be a very big thing. Or if you think of around 5-10 years before, when I was doing a PG, going for a drug sensitivity testing, drug resistant culture, it will be taking 3 to 4 months. By the time we will be losing a lot of patients, we don't know what to do, what kind of medications to be now. But nowadays, with the government effort, with the public-private partnership, you can make sure you can diagnose a patient with drug resistant within 3 to 4 days, or a maximum you can diagnose within 10 to 15 days to make sure that further prevention of drug resistance in the community. So with this increase in the incidence, and one more pathetic thing, where does our country stands? 26% of global burden of tuberculosis is in India, which we are not proud of, and 32, but this I think is significant. 32% of global mortality due to tuberculosis is in India, and multi-drug resistance, 27% of global incidence of multi-drug tuberculosis is in India. So with this background, there was a meeting in Delhi, with Delhi Summit in 2018. Their Prime Minister has launched a program of changing the nomenclature from revised National Tuberculosis Program to National Tuberculosis Elimination Program, with the target of eliminating tuberculosis, to be exact, not 0. It should be less than 44 per 1 lakh population. That is the target. The criteria to set is, by the year 2025, the incidence of tuberculosis should be less than 44 per lakh population, which is the target by the year 2021, which we are driving ourselves into. So the plan is to make sure that you have to make sure you understand the disease, basics of tuberculosis, diagnose, treat, follow up, and build a public-private partnership. Okay. So now I think you will be starting sleeping. Ipadan thukam vara stage agum. Okay, I can incidents, because definitions, there is no other go. You have to, it has been simplified a lot. The definitions has been revised. The classification is just 2. Microbiologically confirmed case and clinically diagnosed cases. Microbiologically confirmed cases, presumptive TB patient with a biological specimen positive for AFB, positive for Mycobacterium tuberculosis and culture, or through an nucleic acid amplification technology, particularly CB0, TrueNOT, so and so, line probe assay, which are all molecular tests. And other is, even if the sputum is negative or whatever it is, you suspect that this patient has got an underlying clinically significant infection of tuberculosis, you can, based on the chest X-ray abnormality, histopathological findings, or the other extrapulmonary feature, which were suggestive of definitive underlying tuberculosis infection. So the classification has been simplified as a clinically diagnosed and microbiologically confirmed tuberculosis. So I told you a presumptive case. Who are all the presumptive cases? In adults, cough, fever, significant weight loss, hemoptysis, any chest X-ray abnormality, at least for a duration of more than 2 weeks. Some of the patients with poorly controlled diabetes will be telling you weight loss and tiredness. These two will be the predominant feature for a poorly controlled diabetic individual. He may not represent you lot of symptoms which he may attribute himself to diabetes. So you have to understand that understanding of comorbidities and diagnosis in an early condition is much important. Same way for children's everything. I think you can know that. Types of TB patients, I told you new patient, and second one is previously treated patients. Previously there was a term in nomenclature of reactivation like that. Now it has been changed to recurrent tuberculosis, previously cured, now again coming up with an infection is recurrent tuberculosis, treatment after failure, and treatment after lost for follow-up, other previously treated patients. So with this definitions, basic definition, I just wanted to highlight what are all the terminologies. You can go and read the guidelines again, so and so. I think it's necessary to read at least 2 to 3 times of tuberculosis guidelines, particularly drug-resistant guidelines, to get an idea of how should we approach a patient with tuberculosis, particularly people who work in a public or government setup. So treatment options, 2 things. Drug-sensitive tuberculosis, drug-resistant tuberculosis. So this is the algorithm. Whenever you suspect a patient with tuberculosis, in the slide, what I wanted to tell is, if you suspect a patient with presumptive tuberculosis with so and so symptoms, do 2 things. Smear examination, chest X-ray. If you found that the symptoms smear is positive, microbiologically confirmed case, and you can start the patient on ATT, but make sure you have to send this patient sputum for CB0. That's the important take-home message. Previously, we'll be sending only after 2 months of treatment, sputum is still persisting positive, or 3 months of treatment of ATT, again we'll be sending to culture. No, no, no. Whatever patient, you are going to start the patient on anti-tuberculosis therapy, make sure you are sending the sputum sample for CB0 assay. Got my point? This is the most important take-home message. By the time you are sending to CB0, make sure you have started the patient on ATT, anti-tuberculosis drug. This is for drug-sensitive tuberculosis. What is about drug-resistant will be coming back again. So, a few points about CB0. So, what I told you, smear examination with chest X-ray, microbiologically confirmed, you have started the patient on anti-tuberculosis drug. By the time you are sending also for an CB0 assay, and again government has told that you have to send it for also line probe assay for first line drugs, even to detect isoniazid resistance, because INH resistant individuals will be developing more time of drug resistant tuberculosis. So you should not miss mono drug resistant, particularly isoniazid. So what the government is advising you, by the time you do a smear examination with positive, you send other 2 samples to CB0 as well as for a first line probe assay. Got my point? So by the time, based on the report, we can revise the treatment. You start the patient on anti-tuberculosis drug. So what about CB0? It's a nucleic acid amplification technology. So this is the thing has been changing from the microbiology, from the microscopic to the lens. Previously, genes. Previously, we'll be seeing everything to microscopic, solid medium, liquid medium, but the time yield to get through a Lowenson-Jameson media is going to be approximately 84 days. It's too much. So things have moved on based on the advent of technology, which multiple number of molecular diagnostic methods. Even now, latest one is a gene sequencing strategic plan based upon gene sequencing assay. So many terminologies have come, new terminologies. So things are going in a rapid way to make sure we achieve the target by 2025. But I wanted to restrict myself to basic thing of CB0, which is nucleic acid amplification technology. It's a rapid diagnostic test. You can get the result at least least in 2 to 3 years along with rifampicin resistance. So rifampicin resistance is important. And you can send any specimen, both pulmonary as well as extrapulmonary specimen for gene expert analysis, except anyone? Except தூங்குறாங்களான்னு பார்க்குறேன் சார். நம்மலாம் கண்ணை முடிச்சுட்டே தூங்கும். Except blood, because CSF you can send, madam. CSF you can send, except blood. Anyone? Why? I have asked a question in 15 minutes exactly. Except Pranitha madam will give you a gift if you tell. Blood has got lot of polymerase chain reaction inhibitory substances. You got my point? So lot of PCR inhibitory substances is there in blood. That's why you cannot get good yield with blood in gene expert. You can send urine and stools, but still it has not been in practice. There is no strict against guidelines whether you can send urine for gene expert analysis. You can go, but still now that has not been formulated. Okay, so you can send even lymph node biopsy. Again, one thing, make sure if you suspect tuberculosis, if you are doing lymph node biopsy, what is the instruction you will give it to your oncologist or surgeon who is doing a biopsy? Anyone? Don't put it in formalin. Yes, sir. Please make sure formaldehyde is going to kill your tuberculosis bacilli. If you suspect malignancy or tuberculosis, make sure you do a biopsy. Ask your oncologist or surgeon to cut it into 2 pieces. Send 1 piece in the formalin, send other pieces in the saline. The saline sample should be sent for a gene expert and histopathological examination for tuberculosis. Okay, so you can send any other extrapulmonary specimen to make sure that you increase the yield with tuberculosis. Again, எல்லாத்துக்கும் ஒரு பதில் சொல்லிடுவோம். நெகட்டிவ்னாலும் டிபி இல்லை கிடையாது. That is what is important. Clinical diagnosis, clinical suspicion. In fact, today we tell that there is no entity called clinical malaria, there is no guidelines on thing, but sometimes we do give. Same way in empirical ATT, persisting, prolonging abscess in an immunosuppressed patient, if you have no other go, we will start with empirical ATT. At least rifampicin has got not only anti-tuberculosis action, it has got an action around 11 to 12 in the form of rhodococcus, listeria, lot and lot. It's going to be Burkholder, everything. So there are some instances, in spite of no tissue or histopathological diagnosis, we will start the patient on anti-tuberculosis drug. But you make sure you try to diagnose based on a pathology or a tissue diagnosis. So results of NAT, we all know, MTB detected, MTB not detected. If it is detected, high medium, low medium, and along with it will have a rifampicin sensitive or rifampicin resistant. Because the foremost important is rifampicin resistant. Obviously, you have to start the patient on a multi-drug regimen if the patient is going to be resistant to rifampicin. So where we are standing, we have done a chest X-ray and sputum analysis for a patient. His sputum is going to be positive and chest X-ray abnormality are going to be suggestive of active pulmonary tuberculosis. You have sent it for CB-NAT and other culture methods by the time you have started on sensitive tuberculosis. So we are right now on drug sensitive regimen. எனக்கு புரியறதுக்காக இதெல்லாம் போட்டேன். So previously there was streptomycin, category 1, category 2, category 3, everything have been scrapped off. Okay, whatever it is, single regimen for drug sensitive tuberculosis, 2 months of HRZEH isoniazid or rifampicin, Z pyrazinamide, E ethambutol in a fixed drug combination daily regimen. Make sure these 3 or 4 points, there is no streptomycin. See, now NTEP is moving towards injection-free regimen. May it be in kanamycin, may it be in capromycin, because studies have shown that this has got a more number of morbidity and mortalities, and adverse event associated with these drugs have been more than with the tuberculosis per se. So, NTP is moving towards an injection-free regimen, particularly even for a multi-drug resistant tuberculosis. Previously, the patients have to put 6 to 8 months of injection kanamycin, 6 days per week, Sunday மட்டும் leave கொடுத்துருவாங்க. Everything has been changed off, scrapped off. For drug sensitive tuberculosis, we have to understand that there is no streptomycin right now. Probably some conditions for an hepatitis, if you have no other go for a modified regimen, you can start the patient on streptomycin. But now, right now, I think there is no stock over streptomycin even in government setup itself. So The latest regimen is irrespective of new cases previously treated, because I told you, you are sending for a culture specimen, you are sending for a drug sensitivity to diagnose second line resistance or a first line drug resistance. So depending upon the results, you can treat the patient. No need to have an injection so and so. So the treatment have been simplified to HRZT and 4 HRE. My personal thing is, I don't stop ATT for 6 months. I will make sure I'm giving at least for 8 to 9 months. It's my understanding. It's not in the guidelines. What I feel is extension of around 8 to 9 months will be more effective, particularly in patients with diabetes. Being in a tertiary care hospital, we tend to see lot number of patients with significant comorbidities. Why I will be fearing is, inadequate dose or inadequate short course of action may cause recurrence rate. I personally give for my patients around 8 to 9 months of anti-tuberculosis drug, even if he feels absolutely comfortable and normal and radiological lesions have gone off after 6 months of ATT. This is my personal way of treatment. Okay. These drugs, what is the latest thing in that fixed drug regimen? These drugs are given daily because, what is the concept? Previously intermittent regimen, the studies have shown that relapse rate are more with intermittent regimen compared to the standard of care. So approximately it's around 10.4%. I'm not confident enough. So it has been changed to a daily regimen and fixed dose combination tablet. Previously patient have to take a separate drug, so many tablets. They will be, see, when I was doing PG, I was the one who was taking care of all Tamil. My project thesis were multi-drug resistant tuberculosis. So I per se started around 350 patients with multi-drug resistant tuberculosis, first in Tamil Nadu. So I will be discussing through all over the districts of all Tamil Nadu to make sure every patient who has been started, it will be started by me under guidance of my chief, because Tambaram Sanatorium will be the institution. Every patient will be referred to us to make sure I have to make sure the patient stays there for at least 2 to 3 weeks, because to assess the toxicities and the complications associated with it, and pre-treatment evaluation for psychiatric opinion, everything has to be, thyroid analysis, everything has to be done. So I have started for 350 patients. The success rate was approximately 66.6%. Whatever telling is for first 350 patients of Tamil Nadu, because even with that much of morbid individual toxic drugs with kanamycin, capreomycin, if you make sure the patient takes the drug adequately, the success rate is going to be high. That is why even too much of anxiety to within 5 years we have to restrict. It is possible with aggressive partnership between the private and public care. This is what I told you. Continuation phase may be extended by 12 to 20 weeks. It's minimum of 1 month, 1 year if it's a neurological tuberculosis or bone involvement of tuberculosis. Particularly in parenchymal pulmonary tuberculosis, I will give for 8 to 9 months of treatment. But extrapulmonary, bone, spine or neurological, till I get satisfied that I will be continuing the treatment. Some patient even may need 18 months to 24 months. It's an individual based treatment. If you want to remember how much the dose, 5, 10, 15, 25. Keep like this, 5, 10, 15, 25. 5, 10, 15, 25. 5 mg per kg of isoniazid, 10 mg per kg of rifampicin, 15 mg per kg of ethambutol and 25 mg per kg of pyrazinamide. Pediatrics na 5 கூட்டிக்கோங்க அவ்வளவுதான். Just add 5 with that. Simple as that. I told you advantages: simplicity of treatment, increased patient's acceptance, increased compliance, easier drug management, because in the mari da irukum fixed drug combination. So the rifampicin each strength will be 150, isoniazid 75, Z pyrazinamide 400 and E ethambutol of 275. 4 drugs கொடுத்துருவோம். This is approximately for a 60 kg individual. For a continuation phase, we can treat. So that will be number of tablets depending upon the weight band, how many fixed drug combination. If the patient belongs to 25 to 34 category weight, you can give a 2 drug. It's easy for both for the drug provider as well as the patient who is taking that he no need to have an each individual drug. It's a fixed single tablet, so that the compliance and psychological advantage is going to be high. That's why government has got simplified this much thing. So this is the pediatrics based upon the weight band. Depending upon the weight band, I think you can refer everything in NTEP guidelines. Google searching, it will come. The treatment outcome will classify just for nomenclature. I am telling you, if the patient is completely cured, it will be defined as cured. Treatment completed treatment, but you don't know the end result means it will term as completed. Failure, in spite of ATT, sputum is positive and culture is positive, patient clinical symptom does not improve, we'll term it as failure. And loss for follow-up, most of the patient, particularly alcoholic and smoking individuals, not evaluated, absconded patient, treatment regimen changed. If you find that the culture has come as a resistant or first line drug is going to be INH resistant, you have to change the regimen accordingly based upon the drug resistant guidelines. Was died due to the diagnosis. Okay. Now we are covered with sensitive tuberculosis. It's a simplified treatment with 4 drug and 3 drug in the continuation phase. Duration 6 to 9 months. Wait till the culture report. If everything is going to be sensitive, continue and monitor the patient clinically. That's it. Coming to the drug resistant tuberculosis. Adhe algorithm na. CB-NAT paakringa. CB-NAT it's coming as resistant. What will you do? Anyone? Anyone? Line probe assay as well as for first line resistant as well as second line resistance. Okay. First line drugs na enna, second line drugs na enna. Anyone? Fast. 13 minutes. Naan 2 days munadam padichen. First line drug, you all know isoniazid, rifampicin, ethambutol, pyrazinamide. Second line, group A, group B, group C. Anyone? Group A? Any one drug? Anyone? We'll see. Fluoroquinolone, someone told it's right. We'll see. Okay. So now the report has come as rifampicin resistant. Obviously, what we have to do is, this is the latest thing. Universal drug susceptibility testing. Rapid drug resistant tuberculosis for at least rifampicin. At least rifampicin for all TB notified patients should be done. At least less than 15 days of initiation of your anti-tuberculosis drugs. If the patient is report has come as NAT resistant, that is CB-NAT or resistant, we will be changing it to isoniazid. Further drug sensitivity testing should be done for first line drugs as well as second line drug among all patients with tuberculosis resistant. See, you can see. Based upon this, we can classify the resistant pattern as monodrug resistant tuberculosis, rifampicin resistant tuberculosis, multi-drug resistant tuberculosis, presentive extensive drug resistant tuberculosis, and extensive drug resistant tuberculosis. Clear? This is, yeah, this one. I told you, if the patients, everyone, you are sending for a NAT. Okay, if the rifampicin is not detected, again I told you, you can send for a first line probe assay. It will see for INH. If the INH is resistant, the treatment will be for mono drug resistant. So if the rifampicin resistant, you are sending for an first line as well as second line drug resistant line probe assay. Results will come in approximately, Bukupadi, it will be around 2 to 3 days, but in government setup it will take approximately 1 to 2 weeks. So depending upon the results, we have to classify the patient of which category this patient belongs to, and the treatment will be started accordingly. So previously we will be talking this for PGs. We all, when we are doing PG, LJ medium, but now it's an old one. It gets the result around 84 days. So that's why I told you the scenario changed from lens to genes. So the rapid molecular tests are line probe assay as well as CB-NAT. CB-NAT is cartridge based nucleic acid amplification analysis. So now the focus is more, and then depending upon that we'll sending for a line probe assay, first line drug sensitivity and second line drug. Based upon that we'll classify it. And one thing, please understand that there is no blood test for diagnosis of tuberculosis. There is no serological test. It has been banned. Idella lot of companies we are doing TB IgM, TB IgG. Even some of my patients will come with that blood report. There are no single tests which have been approved by India or authorities to have a diagnosis of tuberculosis. No serological test. With the evidence of serology blood analysis, you cannot start the patient on anti-tuberculosis treatment. Banned. So coming to the drug resistant tuberculosis. So a few points about drug resistance. It's a man-made thing. Most common cause of drug resistance is going to be in 3 things: inadequate regimen, inadequate duration or inadequate dosage, and the patient, poor quality of drugs, and the patient, because of most common thing being an alcohol and smoking, defaulting treatment. These 3 are the common causes of drug resistance. We all know there will be even in cases of sensitive tuberculosis, there will be mutation. For example, INH, it will be approximately 1 in 10 power 5. For rifampicin, it will be approximately 1 in 10 power 6. With the factors I told you, inadequate drug regimen, dosages, poor quality of drug, this is going to be getting amplified. So patient is going to be getting drug-resistant tuberculosis with treatment failure. Obviously, this guy is going to spread to another community for the transmission of drug-resistant tuberculosis. That is why this story is going to go on. So I told you first line drugs, INH, rifampicin, pyrazinamide, ethambutol. Second line, there are 3 categories, group A, group B and group C. Group A belongs to levoflox, moxiflox, bedaquiline, delaminate, linezolid. Group B, RNTCP, cycloserine, clofazimine. Group C, michadallam. Pyrazinamide, amic acid, meropenem, imipinum, cilastin, linezolid, I-dose, INH, whatever it is, it belongs to group C. These are all the categories. Based upon this, in the regimen, we are going to start irrespective of drug-resistant tuberculosis. But make sure that always first hit the best hit. You as a family physician should understand adequate treatment with a drug-susceptible tuberculosis will make sure that prevention of drug resistance is going to be good. These drugs, please understand that these drugs are very toxic. I have seen literally around for 2 years of my patients with MDR patients suffering with this drug. This ethionamide, the cycloserine, lot of complications will there. Ethionamide, intolerable vomiting, cycloserine, psychiatric tendency, precipitation of seizures, innumerable of side effects, paraaminosalicylic acid, thyroid effects. So, lot of toxicities or complications are going to be happening for patients who are taking drug-resistant tuberculosis. In fact, it's very tough for the patient side also. So, it's our duty to at least we'll try and make sure that we adequately counsel the patient to have an adequate treatment and proper monitoring of treatment with drug-sensitive tuberculosis so that we can prevent drug-resistant and further progression of drug-resistant. So, I told you what are all the types of drug-resistant tuberculosis. Isoniazid acid-resistant tuberculosis, resistance to only isoniazid acid, rifampicin-resistant tuberculosis, multi-drug resistant, resistant to both INH and rifampicin, presumptive XDR, MDR plus any one of the fluoroquinolone. Simple. XDR is MDR plus fluoroquinolone plus any one of the group A drugs, that is levoflox, linezolid and anyone? Bedaquiline or delaminate. Okay. So treatment, the one slide for drug resistant because you will be getting confused. I think you can go through again when you go back home. For monophasic, only for INH resistant tuberculosis, simple thing, replace INH with levoflox and continue other drugs for 6 months. This is it. I told you previous that NTEP is moving towards injection-free regimen. There are 2 phases of multi-drug regimen treatment, shorter oral MDR treatment, longer oral MDR treatment. Shorter oral MDR treatment contains around 9 to 11 months of second line drugs, which includes 4 to 6 months of bedaquiline, levoflox, clofazimine, linezolid, ethambutol and I-dose INH. And 5 months of levoflox, clofazimine, pyrazinamide and ethambutol. So I am just giving a background and what is happening. And longer oral regimen, it's about 18 to 20 months. In this 6 months of bedaquiline, 2L, 2C, levoflox, linezolid, clofazimine and cycloserine. This is for longer regimen. Exclusion criteria for shorter regimen. Yark shorter regimen, yark longer regimen. If the disease is severe, patient is pregnant, if the extrapulmonary involvement is going to be high, previously there is a history of multi-drug resistance, go for longer regimen, avoid shorter regimen. Straightforward, simple case of drug-resistant tuberculosis, you can go ahead and fluoroquinolone resistance. If the fluoroquinolone is resistant, obviously is going to go for a longer regimen. So, there are all the exclusion criteria, which patient should go for a shorter regimen and which patient should go for a longer regimen. So, this is the simplified classification as per the latest NTEP guidelines, rifampicin resistance, multi-drug resistant, shorter oral MDR regimen and longer oral MDR regimen, mostly injection-free regimen. So, shorter oral MDR is approximately 9 to 11 months and longer is approximately 18 to 20 months. This is the stage. இவ்வளோ சொன்னாலும் இதுதான் டிபியை ட்ரீட் பண்ணுவோம் early diagnosis early understanding of the disease preventing further complication is the most important thing. What is my aim in this 30 minutes is to make sure that so much of efforts, so much of diagnostic technology, so much of government work is being done. Even though I am in a private setup, government is doing wonderful job, and tracing and monitoring of drugs availability, everything has improved dramatically for the past 10 years, 5 years or so, and a lot of guidelines have been coming to treat tuberculosis free India, and also the toxicity of the drugs, particularly injectables, have been removed, and drug availability, particularly with bedaquiline and delaminate, has gotten remarkable improvement in the treatment of tuberculosis. Any words about bedaquiline, delaminate? Anyone? Wanted on the slide podla. Anyone bedaquiline? Any point about bedaquiline? Edavadhu enna toxicity cause pannum? Somebody told cardiac. It will increase the QT prolongation and arrhythmias. That is why you need to have a cardiac. It's a diaryl quinone. It inhibits ATP synthase. Dose la neenga padichukonga. I think 400 mg for 2 weeks. Adukapram vandu 200 mg thrice a day for rest of the time for 6 months. So it has got. You have to understand that it has gotten significant QT prolongation. So you have to make sure that you pre-cardiac treatment evaluation. And diaryl quinone, delaminate is one another drug. It nitroso-hydroimidazoles. It will act by inhibiting mycolic acid as well as by release of nitric oxide, which will have a toxic effect to the bacteria. Onnume purinjirukadu. This delaminate. So this has gotten significant. These two drugs have gotten significant effect in understanding of treatment of drug-resistant tuberculosis. So there is a hope in the future that even for a drug-resistant tuberculosis with significant involvement and underlying comorbidities, people can be cured. I just wanted to highlight these 5 conditions because you treat pregnancy, please make sure category drug-sensitive tuberculosis can be continued. Drug-sensitive tuberculosis in pregnancy can be continued. No drugs are going to be teratogenic. Whereas if the patient has got drug-resistant tuberculosis, if it is less than 20 weeks, advise MTP. Okay, because the toxicity of second-line drugs is going to be very high, particularly ethionamide, cycloserine, lot of drugs. So pregnancy category 1, routine sensitive tuberculosis, you can carry on. But in drug resistant tuberculosis, you have to make sure that patient understand that teratogenic toxicity is higher. Breastfeeding, please make sure patient continues the breastfeeding to the child. So mother has to be advised about the cough hygienic measures. Breastfeeding has to be continued and full course of treatment. Pre-treat the child. After ruling out active tuberculosis, congenital tuberculosis to a newborn, born to a microbiologically confirmed tuberculosis case, if there is no active evidence of tuberculosis, you start the patient on tuberculosis prevention therapy, isoniazid, 10 mg per kg body weight for 6 months for children. Okay? So this is important. And diabetes, please make sure absolute strict glycemic control should be there. It has got an increased morbidity along with mortality, and sputum negative conversion rate is also going to be delayed with poorly controlled diabetes. This is what I am telling you from the first slide. And all HIV TB co-infection, irrespective of ART, may HIV patients with CD4 count of 684, sir, patient is having good CD4 count, shall we wait for ART? No. All tuberculosis patient with HIV infection, you have to start the patient on ATT. CPT na enadhu? CPT, anyone? CPT. HIV vanda enna drug poduvom regular orthirukku? Cotrimoxazole preventive therapy. Okay, start the patient on anti-tuberculosis drug, cotrimoxazole preventive therapy, and ART irrespective of CD4 count. So this is what I am telling. And one more important thing, if you diagnose a patient with HIV, and I always wanted to finish before time. If you diagnose a patient with HIV and there is no active evidence of tuberculosis, now the latest guidelines is, even if there is no active evidence of tuberculosis, start the patient on INH preventive therapy. Okay, the dose is 10 mg per 300 mg plus pyridoxine for 6 months. In pediatric population, 10 mg per kg. So even if there is no active evidence, if you diagnose a patient with tuberculosis, INH preventive therapy is important. With liver disorders, please make sure that these drugs, hepatotoxic drugs, INH, rifampicin, pyrazinamide. 3 drugs are more commonly hepatotoxic. So when the patient is symptomatic, if the enzymes are more than 3 times, if the patient is asymptomatic, if the enzymes are more than 5 times, make sure you go for a modified regimen. And restart pandringenu vainga. If you are restarting LFT normalize aayirukku, restarting na as per the guidelines, INH, rifampicin, ethambutol, try to avoid pyrazinamide as much as possible. This is as per the guidelines. But what I do is rifampicin first, INH second, and ethambutol. I'll try to avoid pyrazinamide once the patient has gotten hepatotoxic potential. Okay. These are all the regimen. Inge matunda guidelines have been released with the she or yes. Okay. But still there is no availability with government. Renal failure, H and R are safe drugs. Pyrazinamide and ethambutol have got little nephrotoxicity, but may mark one point. Absolute contraindication of rifampicin is two things: thrombocytopenia, and second one is acute interstitial nephritis. If the patient has got an acute interstitial nephritis, you should stop the drugs. Post-renal transplant, rifampicin has got an ectic drug interaction, particularly with tacrolimus and mycophenolate mofetil. You have to replace rifampicin with rifabutin regimen. Dose, I'm not sure, I think 150 mg, but it has got significant side effects in the form of pseudo jaundice, anterior uveitis, body myalgia. PG period la padichadu, but rifabutinum ipo available angiradhu I'm not sure of. Steroids, don't start steroids for all cases, particularly in life-threatening condition with TB meningitis, massive pleural effusion, massive pericardial effusion, endobronchial tuberculosis with compression, genitourinary tuberculosis with stricture of urethra. In the Mari conditions, you can start steroid 1 mg per kg of prednisolone or 0.6 mg per kg of dexamethasone for 4 weeks and then taper accordingly. Got it? So we all should make sure that what is necessary, we understand what is tuberculosis, where our country stands with significant 26% incidence, 32% mortality, and 27% of multi-drug resistant involvement. It is high time, just like an awareness like today, we need to cooperate with others and make sure that we make sure we have strong partnership in controlling tuberculosis and make sure we achieve the target of elimination of tuberculosis by 2025. These are all so much of web portal, Nikshay, Arshudi, so and so things are there. Web portal is an uniform ID you will be given once you are enrolled, and wherever you go, that single ID will be there. You can be traced of tuberculosis, and lot of government remuneration have been advised for patients as well as for the doctors. And also there is a rule that you can be penalized for 6 months to 2 years of imprisonment if you fail to notify tuberculosis to public. Section 270, no sir? Yes. So it's our duty to make sure we understand what is drug-sensitive tuberculosis, what is drug-resistant tuberculosis. All the available technologies are available everywhere, even in primary healthcare setup. So it's high time to we understand, we diagnose the patient based upon the clinical history and his symptoms, and also assessing his comorbidities and treating their comorbidities accordingly, and making sure that we support our country in eliminating tuberculosis by 2025. These are my aim is to make sure you understand what is happening, what are all the types of drug-resistant tuberculosis, and where we are, and we should unite in eliminating tuberculosis. And thanks once again for giving me this opportunity. Thank you, thank you, thank you. Thank you.
Thanks, sir, for the excellent presentation. Sir has stressed the importance of physical examination and suspicion, as well as simplify the diagnostic algorithm very well. Only one question. How to diagnose pediatric TB? Is it that the algorithm is different from adult?
Yes, sir. I specifically avoided pediatric. It will take around 15 to 20 minutes. So
based
upon the presumptive base, I think you can. I specifically invited our Deputy Director of Sivagangai to make sure this kind of, in a simplified way. So.
Sir, diagnosing tuberculosis in pediatrics is a very challenging thing, because they want to expectorate the sputum specimen. If you need to confirm it by microbiologically, we need to take nasogastric aspirate from the baby. Otherwise, you can diagnose with radiologically by mediastinal adenopathy, looking at the X-ray, and MANTO supporting the MANTO evidence, and the pediatrician can have a high clinical suspicion, can start ATT.
Based upon the clinical symptoms, gastric aspirate. I personally feel, based upon CT imaging with mediastinal adenopathy, pediatrics la MANTO will be effective, sir. But whereas in adults, I don't take personally MANTO as a fetching evidence for starting initiation. Whereas in pediatrics, particularly in extrapulmonary tuberculosis, it can be effective in diagnosing and treating the patients. But the gastric aspirate incidence is also not, yield is also not high, sir.
I'd just like to make one more comment.
Yes.
In our area, tuberculosis was rampant. 25 years ago, it was 10 times the state incidence. And the most important step we took in eradicating TB, largely in that area where there's hardly a case now, is the contact tracing. I think that's crucial.
Yes, sir.
We can't eradicate TB without adequate contact tracing and treating latent TB as aggressively as we treat active tuberculosis. Without that, we're not going to eradicate tuberculosis.
That is the importance of notifying to public health setup. See, government has designed specific personnel to contact tracing. In fact, contact drug-resistant tuberculosis, there are a lot of regimens. 6HR, 6R, 6L, so a lot of things are there. Even for contact patients of drug-resistant tuberculosis, to prevent tuberculosis, preventive therapy guidelines are there. Even for latent infection tuberculosis, one study has been going on, I think in 2 districts in Tamil Nadu, with weekly 1 regimen of isoniazid with rifampicin for 3 months. Weekly once of. The results will be emerging out soon, and so that it will help us. Yes.
Is there a role for clarithromycin as a second line drug?
Only for Mycobacterium avium tuberculosis, particularly in HIV patients with avium intracellular, we will be giving with clarithromycin, ethambutol and rifampicin, madam, rifabutin. But as per the latest guidelines, clarithromycin have been removed, madam. Previously it was there, but now it's the, and it has been specifically mentioned no role of other drugs. But personally, for Mycobacterium avium tuberculosis individual first point, non-tuberculous Mycobacteria, particularly in nodal extrapulmonary tuberculosis, non-responding to conventional drug, I will add with the clarithromycin to assess response.
Regarding diabetic patients, sir, already on anti-tubercular drugs, what is for them?
I personally prefer strict control of glycemia through insulin. Till the patient is taking 9 months of whatever duration of ATT, I personally advise, ask my diabetologist, or in fact our diabetologist will be giving only insulin, because it's like brothers. When you don't control other, obviously the other is going to go.
But
if the HbA1c is in a borderline range and if it is controlled, you can try with oral hypoglycemic. But if it is a poorly controlled with high HbA1c, probably I will go with insulin.
If they are already on OHS, can we continue that?
If it's an adequate control.
Yeah, if it is glimepiride that they are continuing, it's somewhat
yes,
safe.
if it is under control.
Yeah, that group is safe.
I don't want to say in a forum that you can continue OHA, but prefer insulin.
Yeah. Please don't use metformin on that.
Can I just want to thank sir for the excellent talk and very interesting and very keeping us awake after lunch. One patient I just wanted to discuss, I'm sure others will be there. Last year he was started on ATT, detected to be resistant, started on MDR, 2 months taken, developed some skin rash, stopped ATT for a few weeks, then didn't take. Now after a year again restarted, again he developed skin rash, again stopped. So that's an MDR TB.
Yes, sir. Refer to public health authorities.
Referred, then they restarted. And
I think you have to challenge with each and every drug, sir. Single drug. What just like for ATT-induced hepatitis, if the HIV is in LFT is in improving trend, you can start one drug with rifampicin and isoniazid. Just like that, you have to. We will discuss with dermatologists. Even for first-line drugs with isoniazid, rifampicin, ethambutol, some patients will develop itching or rash secondary to pyrazinamide or ethambutol. We will be challenging with each doses of drug. Will be monitored every 2 days, and which drug is having a response of rash, will be avoiding that drug. It's about challenge, sir.
We do that for our hepatitis patients, but in MDR-TB to admit in the hospital and
yes, sir. The government has got an adequate setup to admit the patient. Even for months or years, they will be making sure that they will be treating, sir.
Can we have the last question, because we are running out of time?
I'm ready to go, sir.
Yes. I just have 2 questions. One is the INH prophylaxis for not having active TB. There are some controversies that it can develop resistance. So I want to know.
No, that was previously, there was a controversy. Single drug kudutha vandrum, rifampicin mattum kudutha vandrum. Even now we see lot of prescription with rifampicin. Fever sariyavalana old prescription la pathina rifampicin mattum vandrum. But it has been changed, and studies have shown. All with the study results, the government has changed. Probably what is the latest thing is the incidence of INH resistance, the propagation of patients or progression to multi-drug resistance is going to be high. even with a 10 power 5 ratio or 1 is to 10 power 6 with rifampicin. That is why there is INHA gene, CATG gene, RPOB gene analysis with that. In the guidelines, if the patient has gotten both INHA and CATG mutation, you should not start shorter oral MDR regimen. If the patient has got only INHA or only CATG mutation, you can start with the shorter oral regimen. All these are all because of the results. Earlier we thought that because of wild mutation with a single drug, the mutation is going to be high. But what has now been understood that you can have an INH resistant bacilli because the virulence is going to be less. That is why you saw that even though INH resistant with an MDR regimen, you have the treatment with high dose INH, because INH resistant organisms will go for multi-drug resistant, but they are low virulent. What is the meaning of low virulent? The transmission is going to be less. That is why 900 milligram of higher dose. That was previous. Now it has shown that this preventive therapy are more likely to be benefitable than with combination. Yes.
Role of steroids in TB larynx, suspected TB larynx, is there any role?
Yes, yes, TB larynx I told you. TB laryngitis with severe inflammation with vocal cord involvement, short course. I will prefer for 5 to 7 days. The patient will be responding well. Thank you. Thank you, sir.
Thank you, sir. Now I would like to request Dr. Moses, sir, to honor the chairpersons and the speaker. Sir, I also request you to honor the chairpersons and speaker for the previous session, Dr. Venkatesh Pandian, Dr. John Jacob, Dr. P. Krishnamurthy, Dr. Safir, and Dr. Uma, and Dr. Sheila.
Thank you, sir.